Hello, everyone, and welcome to this clinical lecture. Today, we are deep diving into Neural Rescue, the Therapeutic Hypothermia Playbook. We will be exploring the essential clinical guidelines for managing neonatal hypoxic ischemic encephalopathy, commonly known as HIE. This presentation is fully synthesized from the American Academy of Pediatrics Clinical Report 2026 update. Our goal today is to understand how precise temperature management can fundamentally rewrite the neurodevelopmental trajectory of vulnerable newborns. The evidence for neural rescue. Before we jump into the protocols, let's talk about why we do this. The evidence supporting therapeutic hypothermia is incredibly compelling. Data shows a 24% relative risk reduction in the composite outcome of death or major neurodevelopmental disability when evaluated at 18 to 24 months of age. To look at this from a practical standpoint, the number needed to treat, or NNT, is just 6 to prevent one infant with moderate encephalopathy from dying or facing severe disability. For severe encephalopathy, the NNT is 7. The biological mechanism here is critical. Cooling the brain provides a physiological neural rescue by dramatically reducing secondary energy failure. However, this neuroprotective benefit hinges entirely on timing. It must be initiated promptly within a strict 6-hour window from birth. Managing HIE is a race against time, structured across a distinct clinical timeline arc. First, we have the 0 to 6-hour mark, known as the golden window. This phase is entirely about swift triage, determining eligibility, and rapidly initiating the cooling process. Once cooling begins, we enter the maintenance phase, spanning from Mishagchon, 6 to 72 hours. Here, the infant's target core temperature is locked tightly at 33.5 degrees Celsius, accompanied by continuous EEG monitoring. Between 72 and 84 hours, we begin the rewarming phase. This must be a slow, highly controlled increase of exactly 0.5 degrees Celsius per hour to avoid metabolic disruptions. Finally, on days 4 to 5, we move to neuroimaging. This is the optimal diagnostic window for a magnetic resonance imaging, or MRI, scan to accurately assess the extent of brain injury. Because therapeutic hypothermia is an intensive intervention, we use a rigid 3-step gatekeeper protocol to determine patient eligibility. Gate 1 is biochemical evidence. The infant must present with a pH of 7.00 or less, or a base deficit of 16 or greater. Alternatively, an APGAR score of 5 or less at 10 minutes, or a history of assisted ventilation lasting longer than 10 minutes, satisfies this gate. Gate 2 focuses on general eligibility. The infant must be a late preterm or term neonate with a gestational age of 36 weeks or greater, and they must be under 6 hours from birth. Gate 3 assesses neurological status. There must be clear evidence of moderate to severe encephalopathy or the active presence of clinical seizures. An absolute golden rule in neonatal care: do not wait for sentinel event confirmation. Time is brain tissue. If the gates are met, move immediately. Scoring neurological status, the SARNAT criteria. To safely clear Gate 3, clinicians rely on the SARNAT criteria to objectively score neurological status. We evaluate 6 distinct domains: consciousness, spontaneous activity, posture, tone, primitive reflexes, and the autonomic system. To meet the threshold for therapeutic hypothermia, the neonate must score within the moderate or severe category in at least 3 of these domains. For example, under moderate encephalopathy, you will typically see lethargy, decreased activity, distal flexion, hypotonia, and weak reflexes. In severe cases, the presentation drops into stupor or coma, complete absence of activity, decerebrate posturing, flaccid tone, absent reflexes, and severe autonomic dysfunction like apnea or non-reactive pupils. Navigating the gray areas. While the protocol gives us clear boundaries, clinical reality often forces us to navigate gray areas outside the standard 36-week 6-hour framework. First, consider late preterm infants between 33 and 35 weeks. Standard cooling is explicitly not recommended for infants under 35 weeks, as the data is equivocal, showing no proven benefit and a potential increase in mortality. For infants at 35 weeks to 35 weeks and 6 days, you must have an intense, nuanced discussion with the family regarding risks and benefits. Second, what about late initiation between 6 and 24 hours? While earlier is always better, statistical models suggest a 76% probability of a small reduction in disability even when initiated late. This requires shared decision-making with parents. Finally, for mild HIE, these infants remain at a notable 25% risk for abnormal neurodevelopment. However, because therapeutic efficacy remains unproven outside of ongoing clinical trials like COMET and TIME, cooling mild cases is currently restricted to research only and is not recommended as standard care. In many clinical scenarios, the infant is born at a community center and needs to be moved. This relies on a highly coordinated spoke-to-hub transport network. At the spoke, or the referring hospital, your job is to initiate passive cooling immediately by turning off the radiant warmer. You must monitor core temperature constantly to prevent overcooling below our targets. During the transport phase, an ambulance or flight crew takes over. Servo-controlled active cooling equipment is strongly preferred over passive methods here to strictly maintain the target temperature during transit. Once arrived at the hub, which is the specialized cooling center, the neonate receives a multidisciplinary admission, continuous neuromonitoring, and definitive 72-hour care. Take note of the critical warning at the bottom of the slide. Hyperthermia is catastrophic. Even if an infant doesn't qualify for therapeutic hypothermia, you must strictly avoid elevated temperatures. A core temp exceeding 38 degrees Celsius increases the risk of an adverse neurodevelopmental outcome by 3 to 4 times. Once therapeutic hypothermia is fully underway, we enter the 72-hour golden plateau, holding the line at 33.5 degrees Celsius. During this phase, you will observe several physiological shifts. It is vital to know what is normal so you do not panic. Sinus bradycardia and prolonged QT intervals on an electrocardiogram are expected. Benign physiological responses to hypothermia. However, you must actively monitor for true adverse risks. Keep a close eye out for thrombocytopenia, where platelets drop below 150,000, as well as hypotension, persistent pulmonary hypertension, and subcutaneous fat necrosis. Crucially, look at the crossed-out dial in the corner. Deeper or longer cooling is dangerous. Dropping down to 32.0 degrees Celsius or extending the timeline to 120 hours significantly increases mortality. This practice has been completely abandoned. A major challenge during the maintenance phase is managing neonatal seizures, which follow a dangerous iceberg effect. What we see at the tip of the iceberg are clinical seizures, those visible to the naked eye. But the vast majority of seizure activity is submerged. Electrographic-only seizures are completely invisible without advanced monitoring, yet they occur in roughly 50% of all HIE neonates. Because subclinical seizures still contribute to secondary brain injury, continuous video EEG is the absolute gold standard for the entire 72-hour duration to detect this hidden activity. If full video EEG is simply unavailable at your facility, amplitude-integrated EEG, or a EEG, serves as an acceptable secondary option. Pharmacological shifts at 33.5 degrees Celsius. Let's look at the critical pharmacological shifts that occur at 33.5 degrees Celsius. Hypothermia fundamentally alters a neonate's pharmacokinetics by delaying drug clearance and significantly increasing half-lives. First, take gentamicin. Because hypothermia decreases renal clearance, standard dosing intervals must be extended to a 36-hour dosing interval, backed by strict therapeutic drug monitoring. Second, morphine clearance is heavily reduced. It requires a low-dose maintenance infusion setting. Clinicians must monitor the infant closely to avoid toxic accumulation and severe respiratory depression. Finally, pay close attention to the phenobarbital and midazolam interaction. Phenobarbital strongly induces the CYP3A4 enzyme, which increases midazolam clearance. If you stop phenobarbital, midazolam clearance will suddenly drop, dramatically increasing drug exposure and risking severe oversedation. A careful downward titration is mandatory.